Let's do another pulmonary disease patient. We are now in an outpatient pulmonary rehab setting, and our patient has a restrictive lung dysfunction. Any restrictive lung disease, it's difficult to get air in. This patient got a restrictive lung disease from diffuse scarring, from axillary radiation, and a bilateral mastectomy. In your pulmonary rehab setting, you're going to prescribe aerobic exercise. The goals of this exercise program are to improve overall fitness, but you also have this goal of improving chest expansion. Why is that a goal? Why do you think it's important for us to have full chest expansion? Obviously, we need to move air in and out, but couldn't you just breathe faster? Couldn't we just have an increased respiratory rate and move the air in and out? Why is it so important that we're going to talk about volume and trying to increase and stretch the chest? Put another way, why is a tachypnic breathing pattern problematic? Tachypnic is a high rate but a shallow volume. It comes down to the anatomy of our airways. So if I draw a very simplified lung, we have our trachea that bifurcate into the main bronchus, which bifurcate and bifurcate, but also ultimately end as an alveoli. We can separate the lung into two separate and distinct areas. The upper airways of the lung are called the conducting zone. So from here to here, this is the conducting zone. It's the area within our lung that moves air from one place to the other, but doesn't itself participate in gas exchange. So any oxygen that's in the conducting zone doesn't interact with a pulmonary capillary to leave the lung and move into the blood. This is kind of like the highway system that's delivering someone ultimately to a city where they're going to get out of their car and do something. So the conducting zone does not participate in gas exchange. Once you get down here to the bottom, either the respiratory bronchioles or the alveoli, you are in the respiratory zone. This is the area of the lung that participates in gas exchange. So when air comes into the lung, we fill the lung with fresh oxygen, and we deliver that oxygen all the way down to our respiratory zone, where the oxygen crosses the alveolar membrane to get into the pulmonary capillary. But at the same time, the carbon dioxide that was produced in the body leaves the blood, and we actually fill our respiratory zone with that old carbon dioxide that we're going to need to exhale out. The reason I started with this anatomy of the lung is because the conducting zone holds air. In fact, in a typical, like an average sized body, it holds 150 milliliters. It's the volume of air in the conducting zone. Another name for this air would be dead space air. So the air of the conducting zone gives us around 150 milliliters of dead space air, air that does not participate in gas exchange. So the reason I'm talking about this dead space air is because the question was, why is a tachypnic breathing pattern ineffective? Well, at this point, the lung has collected carbon dioxide and it is going to exhale. Okay, so this next picture is going to be the exhalation of this previous breath that's already drawn. So let's redraw the lung. Very, very simplified lung. And where does all this carbon dioxide go that we collected in the previous picture? It's going to start to leave, right? Carbon dioxide is going to head out to the mouth to leave the lung. So at the end of your exhalation, what have we filled the conducting zone with? carbon dioxide, right? So at the end of our exhalation, what's kind of the volume of carbon dioxide we have here? Well, we have about 150 milliliters of carbon dioxide that didn't get a chance to leave. Exhalation is done. Now let's inhale some fresh, clear oxygen from the environment. Here is again our lung. What is the first thing that moves down into the alveoli? Well, it's that same carbon dioxide that was sitting in the dead space, right? And then here comes the fresh oxygen right after it. So this breath, this inhalation, a typical tidal breath is 500 milliliters. And 150 milliliters of that 500 mils is dead space air. So around 30% of every tidal breath is just dead space air being moved up and down. It's not participating in gas exchange. So when you enter a tachypnic breathing pattern, and tachypnea again is increased rate with less volume. What if we went, instead of having 500 milliliters of a tidal breath, we had 300 milliliters? Because our chest is really tight from scarring or fibrosis or whatever is limiting our ability to get air in, we're only able to get 300 milliliters in. But we could increase our rate. But what have we done to the efficiency of breathing? If our tidal breath is now 300 milliliters, that means that 50% of the air that we're breathing in is just dead space air. Air that has not participated in gas exchange. We're using an incredible amount of respiratory muscle strength and energy just to move dead space air up and down and up and down and up and down. So it is a much more efficient breathing pattern if you can increase the volume, because the larger the volume of your breath, the smaller the total percentage of dead space air. Because dead space air is always going to be 150 milliliters. If you could take in 1,000 milliliters, then you're using energy to move a greater amount of fresh air and a smaller percentage of just moving dead space air up and down. So when we use deep breathing, it actually decreases the work of breathing. This kind of helps to explain the physiological reason why when we exercise, we increase volume first and rate second. Because it's inefficient to breathe just faster, because you're just using muscular energy to move dead space air up and down. If you can take a larger volume of breath, you can get more fresh air and a smaller percentage of dead space air. This is a textbook image explaining the same thing, looking at tidal volume of breath here in milliliters. So 500 mils is a typical tidal breath. In this picture, the kind of solid teal is the volume that participates in gas exchange, and the purple striped is that natural anatomical dead space air. You can see how the proportions shift when you decrease your tidal volume breath. The anatomical dead space air stays the same. It's just the volume of your upper airways. So if you decrease your tidal volume, all you're losing is gas that's participating in the exchange of delivering oxygen and picking up carbon dioxide. So the why are we trying to improve chest expansion for this patient is if they can become more flexible in their chest and allow a greater volume of air in, they will have a more efficient breathing pattern. So that's the why. Now let's look at the how. We're prescribing aerobic exercise, and one of the goals is to improve chest expansion. How does exercise do that? Do you think there's any reason that this should change the flexibility of the chest? Or maybe even, do you think there's any reason we can change the flexibility of the chest? I think you guys would all agree, hopefully, from this picture. Can you change the flexibility of the hamstrings? Absolutely, right? Can you change the flexibility of the chest? For sure. But how do you do that? It's really easy to think about how to stretch the appendages, right? Just take up all the slack and pull, and it stretches. That's very simplified. Obviously, there's lots of interesting and cool things we can do with peripheral flexibility. But how do you stretch the chest? How do you do this with a chest? How do you take it to its end range and pull on it? Well, we do have devices that can help. This is an incentive spirometer where you can tell the patient to take a deep breath in, and they can look at the feedback of the unit to see how much volume they took in. Maybe that would stretch it over time. But there's a big limiting factor here in that this is completely patient dependent. They have to try really hard. They have to know how to use the device properly. They have to be willing to use the device, and they have to have the respiratory muscle strength to do the device. So there's a time and a place for this. But what if we could stretch the chest without the patient even needing to know what's happening, not needing to buy in, and just have it happen? What is the respiratory response to exercise? When we have increased oxygen consumption in the muscles, what must happen to the volume of oxygen being taken in by the lungs? We increased minute ventilation, and we did it by increasing volume primarily. So this is just a reminder of our volumes and capacities. You can see tidal volume here in the middle, which shows this huge inspiratory reserve volume. All this volume we could tap into if we needed to. This expiratory reserve volume, we could exhale even further. We have a huge vital capacity that largely goes untapped at rest. So this is minute ventilation on the x-axis. And you can see that as we increase minute ventilation, we're tapping more and more into these reserve volumes. When we exercise, we naturally, physiologically increase our volume. Which might be a good time to say, how? How does your brain know that your muscles need oxygen? I think an easy place to look, or if you had to guess, like if you had no idea and you just said, what do you think? How does the brain know? I feel like the intuitive answer is, well, if your muscles are using up more oxygen, then there's less oxygen, so your brain says there's not enough oxygen, so it drives it. But that's actually not what happens. So look at, this is exercise time on the x-axis. You can see when exercise starts, there is this teeny tiny dip in oxygen, but then it's completely maintained. Normal oxygen levels during exercise. We do not see oxygen numbers dropping. So a drop in oxygen cannot be the stimulus for the pulmonary response, because it gets bigger over time, right? At greater intensities, you get a greater and greater respiratory response. But if you look at what's happening to our PO2, it's gone unchanged. Just get this off of here. Could it be that we're accumulating CO2, carbon dioxide in our blood? It's also not the trigger. Maybe a little tiny spike, but then completely maintained. So it's not that greater and greater and greater amounts of carbon dioxide are accumulating and stimulating our pulmonary response, but yet we see this big increase in our ventilatory response that's sustained over time. So the respiratory control during exercise is a very dynamic and complicated system. The more important certain parameter is in the body to the survival of the whole animal, the more redundant pathways we have to control it. So this is a little confusing, and there are a lot of overlapping things communicating back to the brain to make sure we have enough oxygen. But as you can see, the first point in your notes under respiratory control during exercise, this is not driven by dramatic changes in blood gases. So it is absolutely an abnormal response to see oxygen saturations going down during exercise. We should be maintaining oxygen levels during exercise. All right, so these control centers of ventilation. The first, we have higher brain centers. We have locomotor areas in the cerebral hemispheres, the pons, and other brain regions. And this is by far the number one most important primary drive for ventilation. So these higher brain centers send feedback to cell bodies in the medulla oblongata that basically tell it how to control the respiratory cycle. So we know that the brainstem is where this control is, but it's dictated in all these feedback loops. Okay, so higher brain centers by far the most important, but we also have our peripheral chemoreceptors. All right, so our peripheral chemoreceptors are sensing the chemical environment of the blood. How much oxygen, how much carbon dioxide. Now let me make sure I make a clear point here between rest and exercise. At rest, the chemical state of the blood exerts the greatest control over ventilation. So at rest, changes in oxygen and changes in carbon dioxide have the greatest influence on ventilation. During exercise, our ventilatory response is separated from that because, as I just showed, blood gases are maintained, and yet we have this increasing and maintained high volume activation of our respiratory system. So peripheral chemoreceptors are sensing the chemical state of the blood, so drops in oxygen, elevation in carbon dioxide, acidity, changes in temperature, can all be dictated and change ventilation. At rest, carbon dioxide is the most important. That's actually what stimulates our breath, is our need to clear CO2 rather than big drops in oxygen. During exercise, the peripheral chemoreceptors are there to help fine-tune the pulmonary response. So it is the driving source of information for ventilation at rest, during exercise, it helps fine-tune the response. Then we have mechanoreceptors. We have mechanoreceptors in the lungs that sense stretch on the lungs, which this is an interesting one. The mechanoreceptors actually function to inhibit breath. It inhibits inspiration and stimulates expiration. You can kind of think of it as a protective mechanism so we don't overfill the lungs. And then we have proprioceptors in our muscles, in our joints that are feeding back to the system and telling the brain and feeding back to our respiratory control center how hard our body is working. Now, studies that have looked at respiratory control during exercise have eliminated one of these at a time or different combinations of these. There is no single mechanism that can explain the ventilatory response to exercise. It is a complicated intermixing of signals, from blood gas measurements to physical stretching to proprioception to higher brain awareness of what we are doing, all coming together to control breathing. So a patient who's having difficult time getting air in, and if the cause of that is a restrictive, especially if it's a skin, muscle, tendon tightness that's limiting, we know how to stretch it. And we will go into detail in cardiopulm about manual techniques and specific stretches that really target the chest. Incentive spirometry is a mainstay for getting more air into the lungs. But it's completely dependent on the patient. And this is a tracing of somebody who's trying their best during an incentive spirometer. And you can see for a few seconds, they can hold it and get the air in. And maybe they do this 5 times. Or you could activate all of these integrated systems, higher brain centers, peripheral receptors, proprioceptions, to feed back to the brain to an automatic physiological response that causes you to increase your tidal volume for the duration of your exercise. If they're tolerating 20 minutes of exercise and every inhalation is a big, huge breath, which of these two is more effective at stretching the chest? I have to argue that the overall load, the stretching load, is so much greater during exercise. Plus, you don't just get the one thing. This is a big cardiopulm issue, but I think it's for all PT. When we prescribe something for our patients, we want the most bang for their buck. Sometimes we have to give singular, individual, work on one little thing goals. But if you can integrate that exercise in orthopedics, if you can do a strengthening exercise that also has a little bit of balance and core work all built into it, that's so much better than sitting in a chair and just lifting one little weight and everything else is quiet. Obviously, if they can handle that extra load. Think about this. We can get a better stretch independent of patient effort for a longer period of time, plus we get all the extra benefits of exercise. So not to give you my bias here, but exercise is best. If we can get our patients moving, exercise can do so much. And we will spend cardiopulm on all the things we can do when patients can't tolerate exercise. But if they can, exercise is best. Happy note. Don't you wish every pathophys lecture ended with just like happiness and excitement about all the good we're going to do for our patients in this amazing career you guys are going to do? Hang in there. You're almost there. You're almost done. Bye.